Hello, everyone. Good afternoon. I'm Allison Elsner, and I'm the CEO of the San Bernardino County Medical Society. We are very happy to have you with us today. We are hosting our ninth session in our clinical education webinar series. Today is focusing on well child visits from newborn to toddler with our VIP featured presenter, Cameo Carter, MD. Dr. Carter is a board certified pediatrician and owner and founder of Garden Pediatrics in Redlands, California. Before we introduce her, we just want to remind you that we do have two more sessions coming up in this series. The next one is on January 14th, and that will be with Dr. Eric Hansen. And that topic, I'm sorry, it's January 16th, not 14th. And that topic will be effective adult preventive visits, including workflows and shared decision making. And on February 26th, we will finish this series with lifestyle medicine for healthy longevity, nutrition, sleep, stress, and more with Dr. Joseph Scherger. So for today, we just want to remind you to keep your cell phones on mute and your speakers on mute, if you would be so kind. What we'll probably do with Dr. Carter's permission is have you enter your questions into the chat, and then following the presentation, we will go through and present those questions so she can answer them. So we encourage you to enter your questions as we go along. So for now, I am really excited to introduce Dr. Cameo Carter. As noted, a board certified physician in pediatrics and obesity medicine. Dr. Carter is the owner and medical director of Garden Pediatrics in Redlands, where she has cared for thousands of families and built a practice known for its warmth, accessibility, and evidence-based care. She serves as assistant clinical faculty with Loma Linda University and University of California, Riverside, and she's affiliated with the Children's Hospital Los Angeles Care Network. Dr. Carter is also deeply involved in advocacy, both locally within the Inland Empire and nationally, including work supporting the federal bill, ELSA, to improve craniofacial insurance coverage. Dr. Carter is active on social media, using those platforms as an extension of her advocacy, meeting families where they already spend time and helping to bring clarity, context, and reassurance to modern parenting and child health conversations. She's also the creator of the Dr. Lady podcast, where she blends medicine, parenting, and real-world stories from her experiences and the families she cares for. Today, she'll be sharing her expertise on well child care from birth through the toddler years, pairing the science we rely on with the art of connecting with families. We are so honored to welcome you, Dr. Carter, and you feel free to take it away.
Great. Thank you so much for this invitation. I'm so glad to meet with you all today. I'm going to go ahead and share my screen and we'll get started. All right. Is that showing up for everybody? All right, awesome. So thank you for the introduction and this opportunity to talk with you today. Like was mentioned, I'm the owner and founder of Garden Pediatrics and also the Garden Wellness group, and that's also taking into account my board certification in obesity medicine, as well as being a general pediatrician, board certified in that area. I enjoy doing both things. And I'm also the mom of 3 boys, and they were actually quite young when I started my practice. That curly-haired one was just getting ready to turn 2 when I started Garden Pediatrics. And I really look to them and think about them when I think about this topic, which I'm so excited to speak about today. I believe that this window of time is one of the most important and powerful periods of time in pediatric medicine and anybody who takes care of kids. And it's sometimes really undervalued. And so being able to put a spotlight on that today, I appreciate and value. These early visits aren't just growth checks, which of course is important, but this is also where we're establishing our relationship, that foundational time where we're building trust. We're becoming the experts that parents are going to look to and rely on. And in an era that is getting more filled with pseudo experts, with misinformation, this is so crucial and important. A few extra minutes in these early times really sets up our kids for not only better health and wellness, but also that relationship where when they're faced with something later on, we're going to be the experts that they trust. So if we get these visits right, we strengthen child health for sure, but we're also strengthening the family's relationship to medicine. And I think that that's one reason why this topic matters, and why I'm glad to be here today to talk about it. And so we'll just jump right in. So the objectives are that I want to make sure we're covering the growing demands in primary care. And I think it's important when we visit these kind of bread and butter topics that we address that concurrently. Look at where we're getting our guidelines from that direct us, general considerations and updates as we face that. We're going to look at age-specific visits as we go along the periodicity schedule, and additional features outside of that which affect those specific visits. We will touch on efficiency, and I always want to incorporate the art and the science of medicine. So there is this physician who posted something, and it was a number of years ago, that just I think about often. Dr. Fitzgerald said something. She said, "A non-medical friend recently asked me to describe life as a primary care physician. I told her, imagine you have 20 plus meetings in a day, half of them with new clients, all who have urgent needs. Each one requires your absolute best self. You are immediately late for at least 10 of them before you even start. And the real kicker, you must prepare a detailed report and have all the deliverables ready for each one, usually just after the meeting is over. And those meetings, they just keep on coming every 15 minutes. I think about that because that's such a good description of what we're doing as primary care clinicians. And we really accomplish a lot each day. The demands are really high, and those demands just continue to grow. Data confirms what we feel already every day in practice. Primary care workload has exploded. We have fewer clinicians serving more children. Less medical students are choosing to go into primary care. We have more people in my field who are leaving than are going in. Panel sizes have grown well beyond recommended levels. There's good literature for this. The number of screenings and tasks as expected in a single well visit has expanded dramatically. We aren't getting more time, yet that list of evidence-based, what we should be doing does continue to grow. And one author calculated that if we tried to follow every single guideline for a standard panel of patients, it would take 26.7 hours a day. In addition to that, EHR and inbox time now rivals the time that we're spending face-to-face with our patients. Rising developmental and behavioral needs among our population are growing. They're becoming more complex in nature, require more follow-up and more time. And the other thing I'll add to that is that families economically are feeling the pinch of insurances. They are paying more in their premiums every year, yet their copays are going up, their deductibles, their co-insurances, their out-of-pocket expenses are going up. And that will often be felt by the visit. So what they're often doing is they're saving a lot of their concern, saying, well, I've got a well visit in a certain amount of time, so I'm going to bring that to that attention too, instead of just coming in for a visit. So it's really adding to what we need to cover in a visit. So when it feels like we're doing more in less time for more patients, that's because we truly are. So with all of that, it's no wonder that sometimes primary care feels like this ride that we have been strapped into that we didn't quite sign up for. And it brings me to this meme, which I feel like might capture how I feel on some days. But I think that understanding, if we dive more into kind of the history and how this comes about, um, and really looking at our guidelines, specifically Bright Futures, and how they have grown, it can be helpful because this has been shaped with really good intentions. It has been shaped by science, by evidence-based medicine. It's been shaped also by policy on a political and larger level, and also is shaped by culture. So when we understand that, it can be really helpful to kind of put it all into context and decide how to best management. So let's walk through how it evolved, and how we can kind of work with that in a sustainable way. So what dictates our well visits is primarily Bright Futures. And Bright Futures is now contained by the American Academy of Pediatrics. And it really dictates what we do and what we accomplish, those lists that we go through during our well visits. So in 1990 is when Bright Futures initiative was launched by the Federal Maternal and Child Health Bureau. 4 years later, the first edition of their collaborative and grouped guidelines were released. And then 8 years after that is when the American Academy of Pediatrics assumed leadership, bringing it into a whole national center to update and implement guidelines. Now, we actually haven't had a full release of a new set of guidelines since 2017. We're still using the fourth edition. However, every year there are updates, and this is where we go to the periodicity schedule. And we'll see that often the updates, especially in the most recent history, are in like the footnotes and in the clarification of the periodicity schedule. And here you see the periodicity schedule. And so for those of you who are not familiar with it, you might look at this and think, oh my goodness. Now, there is a lot of information in here. It actually is really good and very easy once you get kind of the schema of it all, and explains things very well. And there is a second page that's there that has the expanded footnotes. So you can see the things that are the dots are the things that we need to be doing at certain visits. The stars are often things that are recommended, like screening, and we might do it if they meet a certain criteria for it. And then the footnotes that are there give us extra information when we go there about, further maybe links to learn more about it or what we should be implementing. So before going into the actual periodicity schedule of the well visits, I want to highlight a couple of areas that have either been recently, when I say recently, I mean the guidelines came out in 2017, the most recent published one. So these are within that time frame, have been added. I want to spend special focus on that. And I'm also going to include lead, although we haven't really updated that recently, but it's something that I think is important to highlight, especially because there's a lot of recalls and things we hear over the years of lead being in applesauce packets and stuff like that. Okay, so general considerations. So the newborn tests and screens are often done in the hospital. And I wanted to highlight this because as an outpatient pediatrician, I receive patients from lots of different places, home births, birthing centers, lots of different hospitals in Southern California. And the discharge summaries aren't uniform. And sometimes we have to hunt around to make sure, or sometimes the discharge summary that's sent doesn't have all of this information. And so it's really important to make sure that these things were done in the hospital. And if a patient was born at home or birthing center, that we are making sure we do it on an outpatient basis. So congenital heart disease screening has been such a great thing that was implemented to use pulse oximetry, right hand and right foot. And you want to make sure that you're doing it at about after 24 hours of age, but before discharge. I'm going to stand up for a second because the light just automatically, there we go. So you want to make sure you're using it before the discharge from the hospital. If you have less than 90% on any appendage or less than 95% on both, or greater than 3% difference between those two, you're going to want to make sure to do an echo. I'll also note that some of these things are being done more in birthing centers, but it isn't always being done. So again, really double checking that. 2022, this was updated in a footnote in the periodicity schedule for bilirubin to make sure that we're checking that within 24 to 48 hours. Again, oftentimes this is going to be in the hospital. So we're going to want to confirm that this was accomplished, verify those results. Making sure that we know all their risk factors for high bilirubin is important, and seeing the time at which this was drawn is going to be helpful for us. All newborns are going to get a hearing screen, but do remember that additional screen is needed if you're seeing any developmental delay, if there's a NICU related risk. That would include even some of the ototoxic antibiotics that newborns may get in the NICU. Any associated disorders related to hearing, if there's a family history or if there's been in utero infections. And then the genetic and metabolic screening is so great. I mean, there's things that we can learn about that can affect children's growth and development, and we can make changes so that they won't be affected by it. And there's a really great national mandate that we look at about 80 different conditions. Remember that about 1 in 600 are going to be positive. This needs to be done about 24 to 48 hours after birth. If it is done too soon, you may get either a false negative or a false positive, primarily related to the PKU. So if you're getting something abnormal, you can also just verify what time that it was taken. And if it's a home birth, we want to make sure we're getting that drawn in less than 6 hours. So if you're outpatient and you're taking care of babies, make sure you have a protocol in place for if a patient is born in a birthing center, where do you go? Where do you send your baby to get this testing done? So that is also important for the hearing test. Those are two things that I see often need to be done if a baby's born in a birthing center. And so for us, we have a place that we go to for our hearing. Our local community hospital will do the genetic metabolic screening. And so that's a protocol that we put into place. So this is probably one of my favorite slides to talk about in the whole talk, because growth and development is just so integral to taking care of kids. And one thing I didn't mention is before I went to medical school, I was a preschool teacher. And so growth and development is such an important and fun thing to talk about. And it's super fun for parents to tell you about, because every child is a genius and they're doing amazing things, and you get to be enthusiastic and hear about it. I also love it as a pediatrician because it's almost a little tell of pediatric care, meaning if a child is dealing with a chronic health disorder, disease, their growth and their development might be affected. And so that can be something that if we see them starting to be having delayed milestones, they're not growing as well, it is a good hint that what do we need to dig into a little bit deeper and figure out what's going on. A couple of reminders here for growth, like one plot does not a curve make. It can be a great opportunity to ask questions, but we don't necessarily need to freak out. So, bringing a child back a little bit sooner and saying like, okay, well, is this a trend that's happening? Again, pending the answers that they give you to the questions, if there's breastfeeding related issues, things like that. So it's a really great opportunity. Babies can have, and children can have, rapid changes up or down. And so you have time to work on that. So looking at the trending is super important, and knowing that you can bring them back if you need to double check it. Development. So important to do. So in 2006, Bright Futures recommended that we screen at specific ages. The screening is things like ages and stages questionnaires, the MCHATs, and things like that. Surveillance, though, at every well visit, making sure they're meeting different milestones is super important. And I like to really highlight the gap delay. So a baby may not be hitting their milestone exactly on their 6-month birthday. They might be a little ahead, they might be a little bit behind. If they are a little bit behind, figuring out how far behind. Is it a month behind? Is it 2 months behind? Where are we? And really watching that gap delay, making sure that gap delay is not increasing. If that gap delay is increasing, that is more urgent that we really get in there. We can watch it if we're pacing, if we're still staying that 1 month. That can be something that we watch. And of course, we want to get them up to speed. But really that gap delay increasing is going to be important to look at. Early intervention is so important. That's the EI that I have there on the slide. It is highly effective. It has been shown in different studies to give effects ranging from 0.5 to 0.75 standard deviations of improvements. That's a moderate to large effect. And what's interesting is there's all different kinds of methods. There's all different kinds of tools and things that are used. And largely, they're all showing a lot of improvement with positive outcomes. There is quite a bit of brain plasticity for young children. And so when we get out there early, we're going to see that improvement. So it's so important to make sure we are seeing it and we are addressing it early. And I think one additional thing I'll note with that is access to different sources can be difficult. So keep that in mind when you're doing referrals, because if you're watching it too long and then you do a referral and then it takes 6 months to get in, that can be more problematic for the child. So keep that in mind as you're making those referrals. I love to emphasize play because it's so important. We see that it influences the actual architecture of the developing brain. It helps with their executive function, resiliency, improvements in not only their motor skills, but their cognitive, social, and language domains. I mean, setting up that lifelong health foundation is so important. Now, some parents are better at play than others, just as some of us are better at playing than others. And so this isn't something that you can just assume that a parent knows how to play. So make sure you're talking with your parents about ways that you can play. In 2022, Harvard actually developed this really great resource. It's a website with that's titled Brain Building Through Play, Activities for Infants, Toddlers, and Children. And on there, they have really great handouts that you can give to parents and say, for a 6-month-old, here's some games and things that you can do to play with them. So I really love that as a resource, and will kind of not only kind of observe the way that parents are interacting, do I see some play being demonstrated? But also give those suggestions in that well visit time. Another really important thing to talk about is screens. And of course, we're all talking about that. We're talking about that our social worlds and things like that. And the emphasis has been a lot on children. The AAP recommends no screen for any kids under 2. And if over 2, we're making sure it's very limited, it's high quality, that the parent or the caregiver is interacting with the child while they're looking at the screens, and really not more than an hour a day. If you must do it, things like doing FaceTiming, where you're doing facial interactions and stuff is okay. And again, if you're interacting with them, that kind of mitigates those concerns that we're having. Dr. Mupala is a pediatrician affiliated with New York Medical College, and he's done a lot of work on screen time and how it affects kids. And I don't think this is particularly new, but it's important to emphasize to all of us is that his reviews show that excessive screen exposure in young children is linked to delays in language, social skills, attention, emotional regulation. And those effects are dose dependent, meaning the more time that kids are spending on screens, the more it's affecting those aspects. he really emphasizes that this is just such a critical time for brain development, and screen time is going to displace exactly the kinds of experiences that we're wanting. So just spending time in screens means you're having less time in that responsive interaction, free play movement that we know is so important in supporting healthy development. But something that I really, really, really want to emphasize, and that I don't think we highlight enough, is parental screen use. And this is something I'm incorporating into my well visits as well, is the kids' screen time. And so you might not be familiar with the term, but there's an actual term. It's called phubbing, or parental technoference. And this refers to the interference, intrusions, disruptions secondary to parent using mobile phones while spending time with their children. And the research is frightening and very powerful. So Dr. Blanchniot is a social psychologist in Poland, and she has an expertise on cyber psychology, social behaviors related to digital media, phubbing, smartphone addiction, online behavior, as well as interpersonal relationships and well-being. And her work really reminds us that children don't develop in isolation. A parent absorbed in their phone, again, phubbing, can interrupt that serve and return interaction that an infant depends on. Even brief episodes of parental distraction reduces child engagement. It increases fussiness, and over time may impact social and emotional development. Her work shows us the detrimental effects that these habits also have on parents. And I think that this is really interesting. We see that in parents who are doing these behaviors, their anxiety is increased, their guilt is increased, their stress is increased, and they have a decrease in patience. Also, I think another important thing to note is modeling. Kids do what their parents do. And if we don't want them on their phones, we need to be on them less. So I really want to encourage everybody to make sure that we're not just talking about limiting the child's screen time, but we're also coaching parents to be mindful of their own screen habits, especially when their kids are around them. During caregiving routines like feeding, playing, reading, and bedtime are especially important. So when we counsel families, make sure we're looking at both sides of the equation. Protect that developing brain by limiting the child's screen exposure, and support those strong attachments and communication by encouraging parents to be fully present during these interactions. And this holistic approach is really reflecting what the evidence is telling us. So here's an example. It didn't scan in perfectly for some reason, but this would be an example of one of the handouts that Harvard site I mentioned gives. And you can just print these out and give these to your patients. Shifting gears a little bit, talking about dental health, which is a really important part about health. Before I get into the fluoride, which is part of Bright Futures guidelines, is emphasize what the American Academy of Pediatrics and the American Academy of Pediatric Dentistry say to do. And we want kids to be seen within 6 months of their first tooth eruption, or around 12 months of age, whichever is first. And what I still hear from a lot of my patients is that they're being told different things by their family dentist. So I think that there's maybe a little bit discrepancy in what family dentistry or general dentistry is saying and what pediatric dentists are saying. This is what we're recommending. And fluoride varnish is a really important part. Fluoride is an important part of dental enamel and preventing caries. We know with less caries, overall health is usually better. Our baby teeth do affect our adult teeth. And so Bright Futures recommends that we do surveillance to see risk factors and making sure they're getting the appropriate fluoride. We're looking at this from 6 months to 5 years of age in particular. So it's recommended that toddlers and children get fluoride varnish every 6 months or every 3 months. So when do you decide the which is which? So standard every 6 months. And so if they're established with a pediatric dentist, they're going to usually be getting that at this time. Every 3 months, they may need to, in between times, get that done where they receive their primary care. So doing it more often would be necessary if there's previous tooth decay, if there's a strong family history for dental caries, they're having a lot of sugary drinks and snacks. Now, remember what might also play in is if kids are having bottles or breastfeeding throughout the night, that's going to be a lot of sugary substance that's sitting on the teeth. So that would be an increased risk factor. Low SES, because we might have access to care, but it might not just be low SES. If a parent hasn't maybe added their kid to their dental insurance, then they may not have gone yet. And so that might be something that we need to take care of for them. There's poor oral hygiene. I mean, I do have some parents who just cannot seem to get in there and get those teeth cleaned. So that might be something that we need to help them out with. Enamel defects or inadequate fluoride exposure. So fluoride, usually we're exposed to it before we're actually using fluoride toothpaste, and we don't really recommend fluoride toothpaste until they can reliably spit their fluoride toothpaste. But most of the time it comes from the water. But this is super important to note because depending on different cities and different water, there are different fluoride amounts in it. And so you can go to the USPSTF. They recommend that you start fluoride supplementation at 6 months if there's inadequate fluoride in your water. And so I have a link on there, the CDC's site for that has a link to different cities, different states, and then you can go to different cities to see how much water is in your city or the cities that you serve. So I just looked up Redlands and tried, because every year they'll kind of update what our averages were, and we're at 0.65. So if you follow along on that chart, that means that at none of those ages I would need to do any oral supplementation for fluoride. TB screening, I think this is important to highlight because sometimes we just forget that TB still is around. And so we need to be making sure we're doing the TB surveillance. These are the screening questions. We incorporate that in our practice by having our MAs, when they're checking in, make sure they ask the surveillance questions. And this a little reminder that there is still TB cases, and some do have the CNS involvement. So it's really important that we don't forget that it exists. Vision testing. There's really cool vision testers that are out now. Snellens and stuff usually start after age 3 when they can either reliably tell shapes or letters. But these vision screeners can be really great too. So currently, Bright Futures doesn't recommend that they be used. They're not saying you can't use it, but they don't think you need to do testing unless there's a high risk factor under age 3. And so those high risk factors are listed here. If there's very premature, they should be followed up with ophthalmology anyway. If there's these family histories, if you're seeing some developmental delay, remember we always want to look at those sensory things when we see developmental delay, vision and hearing, and if there are systemic diseases that are associated with eye abnormalities. Lead screening is also important, as I talked about earlier. It just seems like a couple times a year, there's some kind of product recall because there's lead in it. So whether it's a toy or an applesauce packet or something like that, lead is still a concern. So the biggest risk factors, of course, are like the older homes and higher poverty areas, low SES, but food and toys also. Remember, it's a neurotoxin. It can lead to irreversible harm even at low levels. So that's why we're recommending we look at it. Some of that clinical impact can be seen, particularly in children. It can affect their IQ, their attention, and it can really affect their school performance in addition to affecting their organ systems. High doses, of course, can be, is an emergency. So we want to be screening for risk factors. This is, again, something that my MAs do along with the TB screening at those well visits. And Medicaid recommends the blood lead levels be done at 12 and 24 months. Some of us do the lead testers in the office because our compliance isn't great if we are sending them out for venous samples. So we'll look at that, and then if they are meeting a threshold, we'll do the lead testing. And certainly if they have high risk groups, then we may send out for that blood lead level as well. So we're all accustomed to giving advice. We give all different sorts of advice. This is from comedian Tina Fey. This is her advice. Some of this I may recommend, some less, but we get advice from lots of different places. I want to go into the periodicity schedule, and I'm going to go through this a little bit faster than the first half, but I wanted to go through and highlight a couple of these visits. So these are, again, the well visits that are recommended at specific times per Bright Futures guidelines. I put in parentheses the 2-week visit because this is not on the periodicity schedule, yet we who are taking care of babies find this visit very important, and most pediatricians and family physicians and things do this because it is really important. I'll highlight why. But one that isn't often done as much anymore is the prenatal visit, and this is on the periodicity schedule. And it's specifically recommended for high risk kids. So if there's something found in utero that may need some additional care, really important that you have like that little discussion beforehand about what to expect. First-time parents, I find this to be really helpful for them. And of course, anybody that requests it. I think a big question is like who pays for it? And that's what's kind of tough is that, we're all kind of strapped for time. And so what time we're going to put that in our schedule? Is it going to be free? Is it going to be something the parent pays out of pocket? And so deciding as a clinic how you're going to do that. But I do think it should be done more. I do them in my office, and we just have a cash rate that we pay for it. It's not as much as we really should get for that amount of time, but it's something that we want parents to feel like is accessible to them. Newborn visits are so much fun and often take a lot of time, but are really enjoyable to do. And we want to see babies whenever the discharging physician from the hospital thinks that they should be seen, but also within 3 to 5 days of birth is what Bright Futures is saying. Remember making sure that your front office staff is telling parents to bring their discharge summaries is so important, so that we can look through and verify that our checklists are complete, and that we go through all of that history as well. We're going to verify that everything was done that needed to be done. And of note is now we have the maternal RSV vaccine, or recommending the RSV monoclonal antibody. And this is so great. This is our 3rd season giving it, and it's awesome. When you're checking if the mom received it, make sure she got it between 32 and 36 and 6-day time frame, and then you can give it at that newborn visit if you're going to give the monoclonal antibody yourself. This is a really important time for anticipatory guidance, not only how to access your system. If they have a question at night, who do they ask? What are the emergencies? Really preparing them for the things that are kind of most scary to them. It's really important breastfeeding support, and this was something that was one of the more recent highlights in our updates in the periodicity schedules to make sure that we're doing that. Evaluating jaundice, make sure those ins and outs are appropriate, emphasizing safe sleep. Some doctors are talking about vitamin D in the hospital or at newborn. I tend to not talk about vitamin D yet. I mean, as you can see, there's a lot of stuff being covered in that visit, and I don't want parents to be so overwhelmed with all that they have to do. And so I'll really pace this out between the newborn and the 2-week visit. And like I said, the 2-week visit is not on the periodicity schedule, but it is so important. We're looking to see that they're back to their birth weight. And then we're kind of doing a lot more of that instructional anticipatory guidance, making sure that vitamin D, if they're getting breast milk, that tummy time, safe to back to sleep, safety, spending time on their tummy is so important developmentally. And so doing a lot of those things at that 2-week visit. And then the 1-month visit, I'll be honest, some of my experienced parents, if they've met all the criteria and everything's fine, I might skip this one. I mean, it is recommended by the Bright Futures, and so I'm not advocating that for you. But this is one that it may be something that, depending on when you have the 2-week visit and that kind of thing, you may not need as much. But at that time, especially for first-time parents, it's a really, really important check-in. It is important that we start bringing in the postpartum depression screening around this age as well. And we're giving a lot of that anticipatory guidance. At the 1 month visit, I talk about the vaccine anticipatory guidance. So saying like, okay, our first set of vaccines are going to be at 2 months. Hopefully they've received their Hep B when they're in their first Hep B in the hospital. We may or may not have had a vaccine discussions about it, and I'll talk a little bit more in detail about vaccines, but just telling them what to expect is helpful at that 1 month visit. 2 months visits are fun. Parents are loving it because they're starting to see that social smile. They feel like they're getting a little bit back in return, and we're seeing that core strength kind of developing. We're also going to be monitoring for postpartum depression, giving the first kind of set of vaccinations and a lot of anticipatory guidance, what to expect between 2 months and 4 months. The 4 month visit, now they are laughing again, super fun. Rolling over, we want to see, and a lot of times this is going to be directly tied to how much tummy time that they've been doing. We're going to be screening for postpartum depression, giving that second set of vaccines, and I give a lot of anticipatory guidance about teething and solid food readiness at this age. So usually teething symptoms will start about 2 months before the first tooth. And so they're going to be showing that because on average, first teeth come at 6 months. And so they're often wanting to talk about all the drooling or gnawing on hands that their babies are doing. And so that is really important to kind of also normalize and talk about different supportive care that you can give. Solid food readiness is an important thing to talk about. I'll talk about it more on the next slide, but generally the American Academy of Pediatrics has been saying to add solids at 6 months, but we're more and more looking at the researchers showing us that we should be following a developmental window instead of just a date on the calendar. So we're looking that they're a supported sitter. Doesn't mean they have to sit independently, but when you hold them, they can kind of keep themselves up, that they're bringing things to their mouth. When you put something towards their mouth, they open it, that they're interested in food, that they're watching it go into your mouth. And when we see these things happening, that is typically a good developmental window. So, like I said, and this is actually my oldest. This was him exploring spaghetti fully sensory, you can see, so many years ago. So, like I was saying, the AP has said no solids until 6 months of age, but newer research is telling us that the transition to solids should be based more on developmental readiness than a strict date on the calendar. So when they're showing those things that we just mentioned, that introducing solids at that point may actually support them being more open to varied textures, better palate expansion. I don't mean that in size, I mean in palate of tasting, and more acceptance of the cultural foods that their families eat. A study in JAMA highlighted that pediatric clinicians are already shifting toward this more flexible model of complementary feeding, and it's grounded in those readiness cues instead of that rigid timing. And of course, the updates from the food allergy concept have already really solidified this shift. In 2025, so not long ago, I think it was this fall, the Journal of Allergy and Clinical Immunology in Practice, a paper by Dr. Walker and colleagues, reinforced what we've been learning for years now, that by introducing those really highly allergic foods early, like peanut, egg, that kind of thing, and often significantly reduces the incidence of IgE-mediated food allergies. So waiting too long does not offer protection. In fact, it may increase it. So rather than thinking of solids as a single moment, as like exactly 6 months, we should guide families to look for readiness, offer a wide variety of nutritious foods, include the family's cultural foods, and incorporate allergenic foods, those highly allergy ones, early and repeatedly. This approach aligns with what we know already about infant developmental needs and with the strongest allergy prevention data that we have. Of note, one thing I'll add to this is that we do have solid evidence that exclusive breastfeeding till around 6 months supports the gut microbiome. lowering GI infections as well. So it's important to acknowledge that, but there's other things that are going to be helpful to the microbiome too that we're introducing. Um, so watching for that, advising that is really important. And I'd like to add just one important additional note about research and work in a really great book by Dr. Amy Bentley. She's a food historian from NYU, and she's looked at a lot of the modern infant feeding norms and how they emerged with commercial baby food in the mid 20th century. So she described how actually pediatric advice became entwined with the convenience foods, the advertising, and the cultural ideas of that era. So some of what we've been advising is kind of coming from that time. Traditions like starting with rice cereal or introducing one new food at a time were not necessarily early on evidence-based. They often reflected the norms, the products, and the scientific assumptions at that time. So when we look at feeding today through that lens, it reminds us that some of what we've been doing as standard practice is actually historically affected, and we need to be bringing more and updating more with the emerging research. So the goal isn't to dismiss the earlier guidance. It made sense with the evidence and the context available then, but the goal is to really update our recommendations thoughtfully as new evidence emerges. And so still emphasizing and supporting breastfeeding, feeding, looking for those developmental readiness cues, and introducing allergenic foods early and often. And this approach really stays true to the evidence while also giving families a flexibility that aligns with infant development and the cultural feeding practices. Moving on to the 6-month visit then is something we're going to talk about more, and I'm going to keep going because we still have to get through 30 months. So I'll go pretty fast in these last 10 minutes to finish up. So these are some of the great things that we're seeing. I'll just highlight that at 6 months, remember that we want to be, if it's flu season, offering flu and also COVID vaccines under 2 years of age. Anticipatory guidance is really important, that we also add that babies can get ibuprofen at this time. We're going to tell them they're going to be having rapid developmental acquisition between 6 months and 9 months. Really telling them back to, ways that we play, but also tell them with language development, narrate their day, narrate, okay, we're going to go get your bottle now. We're going to go do this. Talking to babies. Some parents are a little bit quieter and aren't doing that, but babies, again, are going to learn language by modeling. Then also making sure that child safety is emphasized. Tell parents to crawl around their floor and make sure that there's not things that when babies are crawling that they can get to. And that's a really great way to look for safety things they may not have anticipated. 9 months, we're going to be doing some screening assessments. Again, it's not the testing, but just seeing if they're exposed to lead, and that's part of Bright Futures guidelines. These are some important 9-month-olds in my life. I currently have a nephew who's 9 months old on the left, and that was my boys when they were little with one of their cousins. But this is really emphasizing the development that is happening at 9 months. We're looking at the ages and stages questionnaire. There are different developmental questionnaires you can use, but this one is probably the easiest and most commonly used one. At 12 months, we're also going to add that hemoglobin and lead screen. We're going to have vaccinations, and babies don't have to be walking by 12 months. We let them know it's fine. Everybody's kind of worried if they're not. We don't need them to walk till about 15 months. We're expecting that language development to be starting up. And the current recommendations aren't necessarily to look at word counts anymore, but I still do that because it gives me an objective measure to look at that gap delay. But just wanted to update you that that is something that has been looked at a little bit differently over the last few years. 15 months, again, I'm going to be looking at some objective standard of words that are used. I also warn people about head injuries. Once kids get confident about their walking, their confidence often exceeds their ability, and they'll be having a few more of those topples, and telling them what to watch for is very important. The 18-month visit is even more language development. We're looking specifically at not only our developmental screeners, again, I use the ASQ, but also MCHAT doing our autism screening. And a lot of parents, again, think that by 2, their kid needs to be potty trained. That is not the case. So just letting them know that kind of what good guidelines are, no rush for that. Most boys aren't potty trained until after age 3, most girls until after 2. So kind of setting up expectations for that is important to do ahead of time. 2-year visit, these are some of the things that we're looking at. And I want to keep just point out that Bright Futures recommends that we are looking at considering doing fasting lipid profile if kids or 2-year-olds, toddlers are meeting certain criteria. And so that criteria is listed there. So do keep that in mind because I think that's often overlooked. And now we're rounding out those toddler years, which are so much fun, so crazy. I always say it's hard to stay a step ahead of a toddler. I mean, you just kind of can't. And so you just roll with it. Very fun time. And I say to parents, kind of decide your parenting schema, your structure, your go-to, because we can't make a toddler do things, but you can make sure your behavior and modeling is what you want it to be. That is kind of going through the main visits. Is speaking about referrals and when do you need to refer to a pediatrician. The visit itself is really the framework, but the real impact it comes from kind of what we look at in the tracking and the trending and things. So I say to look at like the 3 T's of referrals. And so looking at timing is for developmentally, is it too early or too late for what we're expecting developmentally? Trajectory, are they really off the curve and I mean that in terms of their growth, but also behavior or their skills, and tension would be the 3rd T. And that can be tension, either you as the clinician or really distress of the family. And if you need that dug in deeper and you're having issues with any of those, getting a pediatrician to look into that is helpful. A word about vaccines. So this could be a whole other topic that we could talk about, but we follow the AAP recommendations, of course, and make sure your clinic has a policy. How are you going to handle vaccine hesitancy? How are you going to handle the anti-vax or you don't want any vaccines? And how do you make sure and how you handle that you're keeping your other patients safe? And I think that those topics need to be discussed and have a plan going forward, especially as this seems to be becoming more and more of an issue. I really value the approach of being open and supportive. Parents love their kids. They're wanting to do what's best for their kids. They're sometimes really overwhelmed by all the information and don't know who to believe and trust. And you can win more bees with honey, I think is the phrase. And so being that trusted person and growing that trust is, I think, so helpful and important. Don't forget the social determinants of health. I mean, that affects our well visits so much. You often hear it say that it's one of those vital signs that's overlooked, and we need to make sure we're constantly addressing it. Sometimes these things are more predictive of outcomes than our traditional clinic metrics. And so figuring out if patients are having a hard time getting in, if there's a transportation issue, if there's a health literacy issue, if we really integrate those routine screens into our practice, then we can identify those barriers better and tailor our interventions in such a way that we can really advance equity and take better care of our kids. Medical home is so important to talk about. The medical home concept was really born in pediatrics in 1967 to ensure that every child received coordinated, comprehensive, and continuous care. And that vision still guides us, even if the reality of these short visits make it really difficult. So ways that we can make that work is, having standing orders in place, paperless automations. One really interesting, huge study that was published in Pediatrics, Ketterman looked at over 50,000 well child checks from July 2022 to April 2024. And the rate of complete well child checks, meaning everything, anticipatory guidance, all the guidelines on all the surveillance and all the screens improved from 45.6% to 84.7% with going paperless. So making sure you're looking into ways that you can integrate electronic screening and things can be super helpful. Standardize your protocols and workflows to reduce the variability and save time and really empower your care teams to execute right person, right job. So when those systems support us, the clinicians can focus on what really we do best, and that's in the connection, interpretation, guidance, and that leads seamlessly into the art of medicine, which is, I think, one of the most important times. We see 20 to 30 patients a day. But for many children, like we're the only healthcare, person that they're seeing. And that's even more, true when they're babies because they're seeing us more often. And these moments are really a gift. Parents trust us with the person that matters most in their entire world. Our science guides us, but it's the art that really honors that trust. So be the trusted voice. Parents are living in this world of crazy misinformation, and our job is to be that steady, reliable expert. Meet all of the questions they have, even those nonsensical ones, with grace, curiosity, and humility. Critical thinking is a privilege of our training, and kindness is a choice that we need to really add to it. We gain more ground with compassion than we do with confrontation. Be an advocate for truth. Become a translator in the spaces where parents already are, including social media. I know some people are more open to that than others, and you don't need to have polished videos. A simple share from another person, a carousel, a fact card can change and influence understanding and build trust. When we show up consistently and authentically, families turn to us instead of the noise. And that has been shown in research and data. Bright Futures evolves, evidence evolves, schedules evolve, but one thing that hasn't changed is families still look to us as their most trusted source for their child's health. The work we do in those well visits, those 15 minutes here, the 20 minutes there, is foundational. So not just for the screening and prevention, but for shaping how parents understand health, development, and scientific truth itself. So my closing ask is this. Let's keep showing up, not only in the exam room, but in the digital spaces where parents learn. Let's find the kind, credible, steady presence that cuts through the noise. Let's advocate for truth with empathy. Let's use the art of connection to amplify the science that saves lives. Because when we do that consistently, we don't just follow bright futures, we help create them. Here's a list of different sources. And that is that. Any questions? I'll figure out how to stop sharing. There we go. Take that off.
Wow.
One minute late. Did it.
You're amazing. I don't know how you choreographed that so perfectly, Dr. Carter. That was really, really amazing. Thank you. You went through the whole gamut there, and those are some great items of guidance for our audience. Dr. Frausto did ask if you'd be able to share the website for the Harvard information and the play exercises.
Yeah, I'll just email that to you. I'll type in because I have the link in there, and I'll grab it and send it to you.
Wonderful. Yeah. And then we'll send it to you, Dr. Frausto. That sounds wonderful. And I'm not seeing any other questions. So we want to ask if anyone would like to raise a hand or ask anything verbally, or if anyone has any comments. I'm not seeing anything. So I think that's a sign that you really covered everything, Dr.
Oh, phew. Either that
amazing.
or lulled everyone to sleep. I don't know. Either way.
No, not at all. Dr. Frausto did write, she would love to have you do a future talk with parents on vaccine hesitancy.
Oh yeah, I'd be so happy to talk to. I mean, it's certainly something that we've been dealing with in pediatrics. My entire career, and it is something that's getting worse. And I think it's important that you address it from a clinic standpoint in terms of protocols and procedures, as well as also interpersonally. And it's interesting to see what is how parents really respond to that. And yeah, it's an important topic for sure.
That's great. I know Dr. Frausto has been really involved in that. So if you two haven't connected yet, you
Yeah.
really should. Dr. Frausto works on, well, she's president of the Cal ACAP, the Adolescent and Teen Psychiatric Association.
Oh yeah, I'd love to connect. Yeah, and it's interesting too. Speaking with adolescents, I'm seeing like teenagers kind of being different than their parents. Like their parents are like, I don't want you to have the HPV, and the kid's like, I want to have it. And I think that agency is something that I'm seeing more. And I don't know if there's any research and data on that, but it's pretty cool to see a little bit of that development taking place.
Well, that's awesome. That's some good collaboration too. That sounds great.
Mhm.
Dr. Case actually has a question. He said, have you had pushback on fluoride as we have had with vaccines?
Yes, I have. And as we all know, like this is again, it's crazy town how so much of the health recommendations have gotten politicized, and there's a lot of misinformation with fluoride. And so I've had some really extended conversations. I have a patient. Mom who's a clinical psychologist who's really concerned about how this might affect IQ. We discussed the paper. She's PhD level, so we were talking about and it was time I took in addition to the well visit. So I have a whole range of uptake. Some they're like, yeah, sweet, give me all the things you can give me, and some people are like, I don't think I'm going to do that. Or I have handouts that I give, and I say like, read this over. If it's not something you want to do today, consider it. And there's a lot of kids who actually don't meet criteria for being high risk, and so they might not all need it.
Right, right, exactly. Does that
Dr.
help,
Case.
Dr. Case?
I just saw his comment. That one popped up. Yeah, isn't it?
Yes,
Isn't
yes,
it? Yes.
exactly. How ironic, right?
Mm-hmm.
Yeah, oh, that's funny, Dr. Case. Good point. Um, well, anything else for anyone else on the line here? I'm not seeing anything. So with that, we will just say thank you again so much,
Oh,
Dr.
my pleasure.
Carter. We really appreciate your time and all your expertise and just your lovely energy that you've shared with us today.
Oh,
And
thanks for having me.
we'll be looking forward to continuing to work with you. I'll put you in touch with Dr. Frausto.
Wonderful.
And let us know if you need anything. And thank
All
you,
right.
everyone on the line. Happy holidays to
Thank
all.
you. All right. Take care.
Thank you.
Bye-bye.
You too. Bye bye.
Bye-bye.